All right. Well, good afternoon. Or good afternoon to most of you, and good morning to some of our panelists who are joining us from the West Coast. This is Brandon Garrett with the National Minority Quality Forum. As you know, it's Friday, so like I said, we like to edutain on Fridays here at NMQF and just sort of present you some of the things that we're working on in the healthcare space. And it's being the last Friday of the month. This webinar, as you know, will be led by our team at SHC, and it'll be led by their very own president, Akeia Blue. Today, we're going to talk about culture, care, and community bridging gaps with humility. And I think that I'll turn this over to experts far more better than I at this space. So, Akeia, introduce I guess, yourself and your panel as well.
Thank you so much, Brandon, and good morning or good afternoon to everyone who's joining us. Thank you all for taking the time to join us today. So as Brandon mentioned, my name is Akeia Blue. I lead the Center for Sustainable Healthcare Quality and Equity here at NMQF, and we go by SHC for short. I'm very honored to moderate today's conversation on cultural humility in healthcare. It is definitely a topic that's passionate for all of us at SHC and beyond at NMQF. We certainly believe that advancing health equity requires a deep commitment to community, and that includes listening and learning and building authentic partnerships that center the voices of those most impacted by health disparities. And cultural humility is an essential piece of this commitment. You may be familiar with the term cultural competence, which can imply a mastery of another's experience. And so we've moved away from that in the field and call it cultural humility, which invites us into a lifelong process of learning, self-reflection, and making sure that we are aware of the fact that we never fully know about another person's culture, but we have that mutual respect and open dialogue to be able to learn and change from what we hear. So today's conversation will encourage you to examine not only your own beliefs and biases, but also how the systems and structures that you work in shape care delivery. You may have seen this week Leslie, who is our program manager on our team at SHC. She has a video about cultural humility around on NMQF socials channels. And in the video, she shares that a clinician once told her mother to remove tortillas, which was a staple in her culture, from her diet because they are just unhealthy. And similarly, I have a West African uncle who was told to remove rice from his diet. And for him, if there wasn't rice, it wasn't a meal. And so if we think about how these types of conversations could have been changed to be more inquisitive, understanding their cultures and the staples of their food that are part of their culture and helping them come up with culturally appropriate solutions that were reasonable lifestyle modifications, that it could have been more successful or just easier to have those conversations and take the opportunity to learn more about each other. Delivering culturally appropriate care requires us to work with patients and communities by recognizing that they are, in fact, the experts of their own lives. No one knows your life better than you do, but we can help them with the tools, resources, and information they need to make appropriate healthcare decisions and actions. So today's panel, we bring together public health leaders, clinical professionals who are actively putting these principles into practice. And as we turn to this discussion, I do want to remind us and ground us all in the fact that culture often becomes a discussion of race and ethnicity, but it can really refer to any part of our identity, for example, our age, gender, religion, and even our hobbies or social groups. And so we want to make sure that we're considering the intersections of these cultures in the patients that we serve. So at this time, I'm going to introduce our panel so that we can get into the discussion because they are the experts and we're happy to have them here. They are community partners with us at SHC and they're on the ground doing the work. So in no particular order, because they're all wonderful, we have Dr. Yabo Baisolo, who's a retired pediatrician, a public health consultant, and the director of health ministry at AME Zion Church. We have Kimberly Rodriguez Hernandez, who is community health program manager at Baywell Health Community, which is an FQHC out in California. And we have Dr. DeLorean Ruffin, who is the Director of Population Health Partnership at the Health Plan of California. So to get started, I'm going to ask each of you to just let us know, what does cultural humility mean in your work? And that can include how patients benefit from it. And I'll just go in the order that I introduced you and start with Dr. Baisolo.
Thank you so much, Akeia, and to the wonderful team at SHC. It's an honor to be here. Thank you for such a kind introduction and welcome to the audience. So as a former practicing clinician, but also a public health professional, cultural humility is the backbone of what we do. And when we serve our patients, it gives us that opportunity to really self-reflect and figure out what our own biases are and what we are also bringing to the conversation to the table. But it's also being open and curious to learn more about the patient that you're seeing, that family that you're seeing. And you'll hear me say this often, we're treating the patient and not the illness. So in order to truly embrace and express cultural humility, we really have to get to know that patient, understand their needs, their aspirations. And it's funny that you said, I'm also from West Africa. When you talk about your uncle, rice has always been a staple of our diet. So when we talk about diet in our families, in our household, is, well, maybe what rice has a lower glycemic index? Maybe we should be doing brown rice or quinoa versus white rice. So all of those things play into how I see my patients and my families, how we treat them, and how we practice public health. Thank you.
Thank you so much. And Kimberly, do you want to share for us what cultural humility means in your work?
Yeah, good morning. Can you hear me?
Sure can.
Awesome. Well, good morning, everyone. For me, really, cultural humility is a daily practice. So it's just not something that we get to check mark every time we do a training. It's really about approaching every patient that we work with curiosity, no assumptions, and really recognizing that they are the own expert in their own life. They are the best person that you can talk to that is going to tell you what is happening and what they would like to focus on. Hearing all your stories, I always think back of when I first started as a community health worker. I had a limited English patient come into my office and we were going to enroll them into a program. And similar to the stories you guys have shared, he was struggling with diabetes, and every time he would see a nutritionist or he was referred out, he was told to follow um, a generic food meal, which is something that was not a part of his culture either. And he would tell me like it's sustainable for about a week or two, and then after that, I can't do it. And it was very difficult. And we took the time to look after, his after visit summaries and everything that he had going on. And I would explain things in a simpler language for him and then have him repeat that back to me. And he said that that was the first time that he really felt seen and heard. And ever since then, he was just really staying on track of his care. He was more engaged in his own care, which was amazing to see that he wanted to get better. He understood what he needed to do and he would implement those practices at home. So it's really about understanding who you're serving and knowing that it's more than just offering different languages for patients.
Yeah, that's a great point. It is certainly more than just languages. It's a lot that goes into our cultures and our identities that we have to consider with these healthcare decisions. So thank you for that, Kimberly. And Dr. Ruffin, if you would share for us what cultural humility means for your work.
Yes, of course. I also agree with Dr. Yabo and Kimberly as well. That's a daily practice, and it does include that self-awareness and not just the languages itself. As a public health practitioner and leader in now the Medicaid space, cultural humility for my work includes a lifelong commitment, essentially, of self-evaluation and systematic evaluation of our programs and processes as well, and learning from individuals' lived experiences of others. And so for my work, it requires a level of acknowledgement and power imbalances and actively listening to patients, our members. And so for myself, my team in population health, we go out into the field and actually prioritize capturing member voices to leverage that for quality care. There's research that shows that patients benefit even more so through improved trust and personalized care. And so in order to gain that trust and that personalized care, you have to get to know who you're serving. You have to understand where they're coming from and what they're experiencing in order to be able to provide that quality of care. And that ultimately is meeting them where they're at in their lives with culturally competent providers that acknowledge that with humility and can practice in that space. And so that's ultimately essential for, of course, building trust, promoting equity, and ultimately striving to achieve meaningful outcomes and care gap closures.
Great. And I think we have to talk about some of the other terms that often come up when we talk about cultural humility. And maybe if we even look at cultural humility as an umbrella for these terms, but when we think about things like bias and health literacy, and even the social determinants of health, how those all play a role in the delivery of culturally appropriate care. So I would love if y'all want to jump in at all and talk about either bias or health literacy. Or the social terms of health, how they show up in the culturally appropriate care delivery as well.
Sure, I can begin with a discussion on health literacy, and just how it plays into clinical practice and work. And I always say this with caution because I don't want it to come across as being demeaning in any way when we say literacy. And we have to be very careful even with that term, because when we say that to someone, well, I want to improve health literacy, they may think, well, I believe I'm literate, I'm well educated, etc. But we've seen, especially over the last 4 years, that regardless of educational level, professional level, there is still this gap there where we still need to inform the public, make them aware, educate them about the principles, say, for an example, of how vaccines work, right? Or how science works, because we may think and assume that everyone has the same health literacy as we do as healthcare professionals, but it can be very different even for those who are educated in other fields. So when we talk about health literacy, is really how are we translating what we have in our minds, what we've been taught, to an audience to share with them so that they can make great choices for their health and improve their health. So for example, when we talk about high blood pressure or we talk about diabetes, letting someone fully understand that those things could be truly related and they don't live separately. So all of those can factor into your overall health if you have one or both of them, and that they can also factor into you now getting kidney disease. So a lot of people will come and say, well, I have kidney disease, but you've also had 10 years of dealing with high blood pressure or diabetes, and all of those things have now led to your kidneys failing because they're all related. So when we talk about health literacy, it's getting to that more granular level for people to understand what it truly means when you say to someone, I have kidney disease. Yes, it may be inherited, but it wasn't just by itself. There are different things that have led to it. So how do you control it? Is by controlling the high blood pressure, controlling the diabetes so your kidneys do not suffer further.
Absolutely. Kimberly or Dr. Ruffin, do you have any thoughts as well?
Yes, I'll add to that. Dr. Yabo mentioned that gap in regarding health literacy. And for me, that's where perception is everything. When it comes to the health literacy and playing a role in delivering culturally appropriate care, implicit bias can definitely shape the clinical decision-making process and communication. Ultimately, that at times is unintentional. And so not every clinician has that level of awareness, even so much so within their practices and in documentation, for example, in medical records. That can also play a role when you're looking at medical records and you see that and you see some of the language that is translated in their case files. That can also have healthcare implications and meanings that can impact the patient's quality of care ultimately. And so translating, as you said, Dr. Gabo, to patients and to clinicians equally, what that means and those implications for patients to ultimately meet them where they are is vital. I mean, using such as plain language and respectful communication definitely supports equity and understanding in that regard.
Adding to what DeLorean is saying, especially around the terms that are used sometimes to describe patients, it's also very important wording, right? I tell my team all the time, different words are going to invoke different emotions for the patient and within you as well. So if you're calling a patient homeless compared to unhoused, that's going to be received very differently in different spaces. So it's always important to understand how you are wording your clinical notes, even for example, my CHWs, so they know that that's also going to get translated in a different way by different people as well.
Yes,
Absolutely. And I think
words actually matter. in those very instances. And it's oftentimes overlooked and underemphasized in various spaces, but words have and play a role in individuals' health and their lives in every day, whether it seems like it does, whether it's weighted or not, it does, and it's a meaningful component to communication and healthcare. Just wanted to add that piece.
Absolutely. And I think as we kind of continue down that path of words mattering, we often hear about difficult patients or, non-compliant patients. And those are terms that we definitely don't want to continue labeling on patients. It's a dangerous game because once you put anything, whether you put the actual words or just sum up the patient in a way that it can be interpreted that way, that follows them throughout their care. And we've done these cultural humility workshops. SHC has done these, and we've seen where clinicians and care teams are able to identify social determinants of health challenges, but then when you ask them to describe what is a quote unquote difficult patient, they actually are describing patients that are having challenges with SDOH. And so trying to bridge that gap and understand the role that things like not having transportation, not having daycare, not having the resources to maintain, not understanding how to take your medicine. Those are all cultural, social determinants of health that can impact how we approach culturally humble care. So I thank y'all for bringing up that point about the words matter. Go ahead. I see Dr. Yabo, you came off of mute, so if you wanted to jump in, please do.
Sure, no, just to expand further on about the words mattering, because we do patients such an injustice in healthcare in terms of our labeling. We lump everything together, calling patients with sickle cell sicklers, or just the hypertensive patient in room 1 or the diabetic patient in room 2, and not seeing the patient, but seeing their illness. And again, we're treating the patient, not the illness. And those words really do matter. And going to your point about the difficult patient, I recently was able to be part of a seminar that the American Academy of Pediatrics had for practicing providers about 2 years ago at the national conference. And we really delved into all of these topics during the seminar, and letting the younger and even the older, more seasoned pediatricians see how detrimental it can be to patient care when one person on the team, God forbid, is the leader of the team, starts off morning rounds with saying, oh, we're going to this room, this is a difficult patient. And then that translates to the rest of the team and how that patient is then cared for, what kind of care they receive from the physicians, from the nursing staff throughout their stay. So it's very, very important that we as healthcare providers really look at ourselves and see how we are contributing to these biases and the way we talk and share about patients. So thank you.
Absolutely. Dr. Ruffin?
Just to further expand on that, where words matter, and that's simply because, and Dr. Ayabo alluded to this, where language is not neutral. It communicates values, assumptions, and power. And so when it's used carelessly, even by the provider, it can reinforce biases and continue to drive disparities. And there's research and studies that show that bias documentation, for example, can lead to reduced empathy, more punitive treatment, and even a diminished quality of care. And that's particularly so much so for Black and Brown populations. And so that's even more of a reason to uphold that mindset of in consideration for culturally appropriate care, essentially.
Absolutely. And I want to keep us down this path on bias because it is such an important topic when we're talking about cultural humble care. There are levels of bias, and just to level set everyone in this conversation, we have essentially 4 levels that we look at. So the ingrained, and that's not the right word. I'm lost the word. Internalized. There it is. Internalized bias, which can either be you promote yourself. You think you're better than others if you are of a group that is typically seen as the majority, or however you want to put it, or you can have internalized bias against yourself. We can have interpersonal bias between one-on-one. So for clinicians seeing a patient, that one-on-one interaction. We can have institutional, which is the healthcare practice, the hospital system, et cetera. And then systemic level, which of course we all know to be the higher level governing bodies, the law, etc. So I'm going to ask you each a question because you each kind of work in a different level of the bias. So starting with you, Dr. Yabo, and we're starting with the interpersonal level as a clinician, can you talk about how you work to drive cultural humility and overcome biases and other challenges as a clinician working one-on-one with patients?
Sure. I think it's really important initially to just really learn as a clinician how to listen actively and listen to truly understanding with feeling. Um, and that's the first part. But then also starting to ask open-ended questions of your patients that you're seeing. So for that individual family or that patient, trying to truly understand what is their personal understanding about their health and their personal belief about their health, and how things that you may or may not recommend would affect their health. So just to truly get an understanding from their standpoint, do they think that they're fine, that they're healthy before we throw these diagnoses and so forth at them and these recommendations? And then once you get to that understanding, then you can start having that open dialogue and conversation with them. But it is just really so important. I think for me, that's what I would recommend to especially the young and upcoming clinicians to really learn how to listen actively, effectively, how to really just sit back, ask those open-ended questions before you rush in and start giving your spiel and, well, this is your diagnosis and this is what I recommend you do, et cetera. Because at that point, we are inflicting some of our biases unintentionally onto those families, and it's really important for us to truly understand where they're coming from.
And that's great. And having that, allowing that open dialogue allows us or allows clinicians to really account for all of the different cultural nuances that people have, because not all Black people are alike, not all Hispanic people are alike, and it gives you that ability to really tailor it to the person. So I appreciate that open dialogue. It's very important.
Yes, and also the opportunity to learn about new cultures, right? Like you're saying, like not all Africans are the same. So people from West Africa are different from people in East Africa, et cetera. Same with us as Black Americans. And so really being open to learning new practices, new cultures. What are the foods that you eat? What are your comfort foods? What things bring you joy? What do you consider healthy in your culture, as far as diet and nutrition, et cetera, and truly understanding that.
Yeah, absolutely. And Kimberly, I'm going to turn to you because you work at a FQHC, so we're talking institutional level now, and you serve diverse population types out in Oakland. Can you talk about how, as an FQHC, your organization provides culturally appropriate care?
Yeah. As an FQHC, we are really rooted in the idea of meeting people where they are. So this really includes honoring their culture, their identity, their language, and their lived experiences. So because we are embedded in these communities that we are serving, many times our teams also reflect those communities, not just racially and linguistically, but through also social realities that people are facing that we can relate to. So culturally appropriate care is, like I've said before, really goes far beyond the translation services. Our CHWs are really cultural navigators in a sense, because they are building trust and bridging those gaps between the clinic and the community. So when we're designing our care plans, we want to respect cultural health beliefs, family dynamics, and preferred communication styles for our patients. And this is really letting our patients define what is most important to them and integrating trauma-informed care into every interaction we're having as well. And this is because we know that many patients sometimes carry the weight of systemic inequalities and generational traumas. So one thing that we really push for is not having patients fit the model of care that we have, but shifting workflows and our outreach strategies based on the communities that we are outreaching to and their community needs. Especially because we know that not everyone communicates the same and everyone has different ways of receiving information. So this is really what makes FQHCs a critical part of the healthcare safety net, especially because we are built to serve people holistically, not just systemically.
I love that. And just knowing the history of your particular FQHC that you work at and knowing that it was founded by Black women in the community and really is rooted in that is it's the having been there and seen the work that y'all have done, it is incredible. And so I commend y'all for the model that y'all put forth and the flexibility you have. And so let's move on to systemic level. Dr. Ruffin, you work for a system that helps to ensure, you know, the healthcare access that's happening across a wide swath of California. So if you could talk to us about what that looks like in terms of cultural humility and addressing social determinants of health for your population.
Sure, absolutely. So within the health plan, within my workspace at the health plan level, systematically, we focus on collecting member experiences, and that includes qualitative and quantitative data, which essentially equates to my teams being out in the field within my department in various communities across the 24 counties in Northern California that we serve to bridge network gaps and build relationships with key stakeholders and community members, and also with the local public health departments that are involved within community health assessments and community health improvement plans to support and provide technical assistance and project management and kind of staffing to leverage patient voices essentially. So some of those regulatory items give us the opportunity to take advantage of capturing the member voice and being able to leverage that, which ultimately informs policy in the design phases and supporting closure gaps within disparities. So being able to centralize member voices and collaborating with various partners throughout the field is very essential within cultural humility spaces as well at the systematic level, because we serve so many of the population. We can't do it all by ourselves, but being able to spread that knowledge and being able to capture and spread that knowledge and trickle that information up to the policy decision-making phase is truly vital in that regard. And then also being able to use data as well to identify disparities and stratify the risk from that regard is also a way that we actively work to address those challenges. And so when we are able to stratify risk, we're able to utilize those risk scores, for example, for comorbidities in relation to, say, a severe maternal mortality, for example, that can be used for making peer comparisons and related to identifying quality improvement opportunities, for example. And so that data for us supports the development of interventions and targeted programs that are tailored towards maternal health equity. And so we have maternal health equity campaigns, for example, that aim to meet individuals and families exactly where they are through the use of incentives to address some of those and consider the root causes of those social determinant health challenges that they face in their day-to-day lives. And so that's also embedded within our processes with our care coordination and benefit navigation and strategic planning, for example.
That's great. And I think what you just talked about helps to highlight how it all kind of works together. You do the systemic level changes, you have the policy changes, implementation that comes down to that institutional level where those systems are able to bring in those changes. And then hopefully that helps with the interpersonal level. But of course, there's work that has to be done on the interpersonal level that is separate from systemic, because even if the laws are in place, that doesn't mean that you are still treating people with kindness. So it really does take a multifaceted approach to drive this work.
Definitely.
And so thank you all for sharing kind of how each of your levels of work contribute to cultural humble care. I want to get into some specific examples because I think it's always helpful for people to walk away with seeing how this works in real time. And y'all have talked about these some, but if there are any other examples or programs or strategies that you've implemented or seen implemented at any of the levels, interpersonal, institutional, or systemic, would love to hear more about those. I'm familiar with from a project that I was working on kidney transplant. One of the hospital systems up in Chicago has a really robust, culturally appropriate kidney transplant program that they've put in place in order to make sure that they are getting Black and Hispanic patients to get on the transplant list. And with the success that they've had in the programs, it's 2 programs. They have one specific for African American and one specific for Hispanic. They have been able to like redefine what transplant care looks like because they've provided culturally humble care with doctors that look and like their patients, speak the same languages as their patients, able to give them more personalized care and answer their questions, bring in the family, because we know for Black and Hispanic communities, often family is important with healthcare decision-making. So with steps like that, they were able to really change the face of transplants in Chicago. Do y'all have any other examples that are similar to those of how cultural home care has been implemented?
I can, just share a little bit more on the individual patient level, how that's been implemented. And we see this with programming, and I'll also touch on a little bit of public health programming. So right around onset of the COVID-19 pandemic, I was involved with a project where we were looking at how we share the seriousness of the flu with different communities. And language, what language do we use to portray that, say, in flyers and graphics, et cetera? So when you look at it from not only public health, but individual level, and some examples of what works is truly listening to the community and finding out from them, because we were all ready to just put La Gripe on the language, but that doesn't necessarily mean the same thing for some Hispanic communities as it does for other communities with regards to the seriousness or the severity of the flu. So it may be seen by some as just a simple cold, and for others, it may be seen differently. So just truly understanding for that particular community what verbiage to use is so important. And so that's one strategy that I've seen work, is truly finding out from the community what you would like, what terminology, health terminology would resonate and make sense for you when you're creating educational material. So that's one example as far as a strategy that, I've seen work, is truly involving the community in that marketing piece.
Dr. Ruffin?
I'll add to that as an example from a previous work experience from a programming perspective as well. There's a program, Eat Well, Live Well, which focuses on health education and awareness in reducing hypertension and diabetic rates amongst patient populations. And so this program, it focuses on that component with primary care, but it also teaches nutrition with a registered dietitian and chef that come on site to our patients when they're in this program, and teaches them how to adjust and eat different nutritious meals and how to cook with those that they may not be used to as part of their regular day-to-day culture, and provides the education to make that translation communication to them so that it lands with them, and then also that they can embed it, incorporate into their everyday lives, into their practices. So that way they're now be able to, they may not always had a knowledge of how to cook or how to eat bok choy and how that may contribute to the positive health outcomes within their day-to-day diet as such. For example, it's just those small, minute examples that can play a vital role in someone's day-to-day lives has an impact on their health ultimately. And so another example of that where we are listening to right now are within the maternal child health space, we're producing maternal photo shoots designed to affirm BIPOC birthing people and connect them to services. And so that goal with that program, for example, is to raise awareness and encourage utilization of our benefits and services, including like doula care and preventive care, and also promoting our Growing Together program that promotes those prenatal and postpartum care and well child visits and the immunizations with a robust, culturally tailored outreach approach to that, where we're able to go into the communities and ask individuals, what are the barriers to your perinatal care, for example? What are the barriers that you're seeing to getting your child within those pediatric visits, for example? Once you're able to understand and incorporate their experiences into policy, then you're able to influence interventions and tailored programming to address those with a culturally tailored outreach approach, for example. And so that's just some examples that we have utilized within our programming to address some of those challenges.
Thank you for sharing those. And Kimberly, do you have any examples you'd like to share?
Yeah, Dr. Dr. Yabo has really hit on this point a lot, and it's listening, right? So it's really integrating our community voice into the design of delivery of care. So not just waiting to get feedback at the end of a program to see how you can improve going forward, but it's as the program continues to move along, taking that patient feedback and using it in that moment to guide quality improvement. Um, just thinking of some of the work that we have done, we were on the Wise Woman program about a year and a half ago. And we originally had started to rocky startup, right, for the program. But as we started to get things moving along, we really noticed that patients were benefiting a lot from coming into their providers. The program was tailored for uninsured women who were at a higher risk for heart disease. So it was really tailored to these women, and we were bringing them in and understanding what they felt was most important in their care and also what they thought they were getting in terms of benefits from the program. And a lot of them started to say that they felt more connected to their care. Now they were looking and visiting at a nutritionist. They were now being seen by a cardiologist if needed. They were getting more health education. And throughout the entire process, they were saying that these were things that they had never really experienced before and that they thought that they were missing. So it's really using those patient voices to guide the work that you are doing at every point, not just at the end for the next fiscal year.
Great. And so I'm going to take a moment to let the audience know if you have any questions, please start dropping them into the Q&A. We still have another question or so for our discussion, but we will have time for Q&A. I do see one question in, and so we will be answering that shortly. But as we get ready to transition into Q&A, one kind of final thought I want us to talk about is making sure we give people actionable steps if they are not sure where to begin with incorporating more cultural humility into their care and assessing their bias, assessing the social determinants of health needs of their patients or the population that they serve. Want to make sure that we're trying to give people some actionable next steps. And so I'll just start with dropping one or two little things, and then I'll ask for each of you if you have any other nuggets to share. So I always have been an advocate for the implicit association test from Harvard University. It is a very short test that anyone can go onto their website and take, and it helps you identify your own biases. And you might be surprised to find out that you have bias that you didn't think you had. And then you have to sit with that and kind of work through it. And I will emphasize what I always emphasize, that everybody has bias. It doesn't make you a bad person. If you take the test and you find out that you have a bias, it's okay. It is okay. It just means that it's time for you to take the opportunity to do some work to see how that bias might be showing up in your care or even in your interactions with people. But that is one resource that I like to share with people. And then SHC is rolling out cultural humility workshops. We've done some already, but these are hands-on workshops to help you identify biases at your interpersonal level as well as at your institutional level, and come up with strategies to overcome those biases that are personalized to you and your organization. So those are a couple of tools. You can feel free to reach out to us if you want to learn more about those workshops. But any of our speakers, if you have any other tools that you'd like to share, please do so. Or actionable steps, sorry, to help people start to move towards this more cultural humble care.
Sure, sure. Those are great examples, Akeia, and I think both Dr. Ruffin and Kimberly have touched on the importance of letting your patients feel valued. So as far as an actionable step that I would share with other clinicians, make sure that you are building respectful partnerships, not only with your patients, but the other staff, and you're building trust there. And let me give you an example, maybe that will kind of help frame it. So we know in many cultures, and I think Kimberly alluded to this, you have to figure out, or you should be trying to figure out, who's the spokesperson for that family, right? It may be different in an African-American family versus a family of Hispanic origin, or it may be different from an Eastern European family. So trying to find out who is the decision maker, who's the spokesperson for that family. So when they come to you and you're in a visit situation, so I'm putting myself as the clinician here, who am I asking questions of so that I show respect? Because that's how the respect translates down in that family. Am I talking to the mom or the dad in that family? And I know sometimes language is a barrier and we have to use the younger children in the family as interpreters, but still showing that respect to the parent or grandparent. Because I'll tell you, growing up, if I walked in as a pediatric patient and the pediatrician or healthcare professional only talked to me and not to my parent or grandparent, we would not be continuing that relationship. So it's very important that we understand how to build those respectful partnerships with our patients and build on that trust. So that's really an actionable step that I would want to share with other healthcare professionals.
Great, thank you. Kimberly or Dr. Ruffin, do you have any actions for folks?
Yeah, I think for my end, I would encourage a lot of regular self-reflection, not just for yourself, but for the team you have or the teams that you work with, especially after heavy patient encounters that you may have. A debrief is really going to help address any assumptions or anything that could have felt off. It really creates a lot of growth space for yourself and for your team when you can debrief on a patient encounter that you had and kind of go through your thought process, and identify some of the biases that you may have or some of the assumptions that came up.
Great, and Dr. Ruffin?
Yeah, I would say some actual steps clinician care teams can take to improve culturally appropriate care would include engaging in regular cultural humility and anti-bias trainings as a business case priority. It's oftentimes overlooked and underutilized and undervalued and underinvested in terms of development. And this may be considered taboo nowadays, but institutionalizing equity through policy, accountability, and investment should be a pillar and perhaps a call to action in reconfiguring, for example, the workforce development arena in the medical field. And so incorporating training as a fundamental part of curriculum for medical students is a start, and training clinicians already in the field systematically to replace biased verbal and written language is also essential. So that's also looking at medical terminology, and sometimes objective medical terminology can even stigmatize patient care and languages in that regard. And so that's being able to analyze that and call that to action is essential step to providing equitable care. And also I would say co-designing services with community voices and evaluating that as well, by re-stratifying that against a race and ethnicity as well. It's highly important for us to center the voices of members, as Kimberly and Dr. Gabo alluded to, with those experiences and shaping those equitable responses in service delivery. And so a tool that is out there from research is the Mindful Language Toolkit that helps to reduce bias in interactions that providers and clinicians can take, for example, that is promoted by the Stanford Language Learning Toolkit that's out there. It's available, I think, yeah, it's available out there from Stanford, but that's an example of a strategy or a tool that can be embedded within curriculum and within the business case, but it has to be a priority from the organization to invest in such trainings and that type of cultural humility lens within their workspace.
Absolutely. And that leads us right into the first question that has been asked, which from Gina, thank you for highlighting these important aspects. Could you please provide specific tools, training resources, or practical examples of best practices? So we kind of have done this to effectively address health literacy, ensure clear patient communication, and manage internal biases within clinical teams. And so I think, as you just talked about, Dr. Ruffin, the training and integrating that into the institutional level, I will say be mindful of the trainings that you participate in. Many of them can be helpful. A lot of times with cultural competency or cultural humility trainings, they end at the recommendations are, put yourself in your patient's shoes, which is a great first step. However, there needs to be more done. It shouldn't end. And if that is where the training ends, then I would recommend finding some additional trainings. The CDC, at least used to, and I apologize because, everything has been upturned in the government recently. So they have had a large library of health literacy tools and trainings even on CDC's website. They also have a preferred terms list, which I have had it saved on my browser for years. It lists a whole bunch of alternative terms that you can use. Dr. Bisolo, please jump in.
No, no, no. I was trying to applaud. Yes, I
Oh.
use that terms list as well all the time. Yes.
Yes, and that speaks to, I believe it was Kimberly who talked about earlier, the language that can be used, or it might have been Dr. Yapo, I apologize, but using unhoused versus homeless, things like that. That list has all the different types of terms, and it's not, it's not to say that you have to go buy it, but it is a good idea to start thinking about the different language you can use.
Yeah, that mindfulness toolkit, that's from Stanford, that's in the Med Ed portal from the Journal of Teaching and Learning Resources. That also has a lot of good examples as well of non-destigmatizing and less oppressive language uses and examples as well with those type of training resources.
Great. And then I think just to close the loop on that question, Gina, again, as our panelists have been very helpful in sharing, it really starts with yourself and reflecting on how you can converse with your patients better, the questions that you can ask that could be better. So even if you aren't able to get to those actual tools, if you're not able to get to that institutional level change, it can start with you on your interpersonal level. But as you're looking for some more specific trainings, they are out there. Harvard is a good resource. CDC has been a good resource. Just look into them, the resource that Dr. Ruffin just shared as well. All right, so moving on to our next question from Esther. This question is for Dr. Bisolo. She says, glad to see you continuing your public health initiatives during your retirement. You indicated that you have had success with cultural humility on an individual basis. Have you made inroads at the organizational level in Atlanta?
Great question. So forging that path, Esther, thank you for the kudos, but yes, forging that path. So currently with my role as the Director of Health Ministry for the AME Zion denomination nationally, it rears its head because the issue is every community, every church community is going to be very different. When I work in the Northeast, it's going to be very different than working in the Southeast, and how people receive information and the culture of that community is very different. So it's a work in progress. So really learning each community, and I think that's the key. Do not go in with any assumptions, really going with mindset of I'm here to understand what the needs are, the health priorities are, not only of your church, but also your community, because they can be very different. We've seen a lot of churches, for example, people may come to church in a particular area, but they don't live in that area. They just go there because they like the church, they like the pastor, et cetera. So two different profiles that you're looking at. What is my church profile, but what is also my community profile? But again, the key is truly listening to learn, to understand what are your needs, what are your health priorities, and now how can we address them?
Thank you, Dr. Bisolo. And Esther wrote in the second part, it says, FYI, I used to be in your Saturday morning walk on the Silver Comet Trail in Smyrna.
Oh, wow. Yes, we did that at one local church. So yes, imagine if we could do that on a national scale. Great to see and hear from you, Esther.
Very good. All right, and let's look at some more. So Robert, thank you. He has dropped in some links for resources, and I don't know that everybody can see these. So what we will do is send out an email after, the webinar later today with any resources that we want to collectively share with everyone. So thank you, Robert, for sharing those. Okay. Roshalda has said, this has been very great, very enlightening. Will a recording be made available for reference? I found myself not able to write fast enough while listening to the pearls of wisdom and have gaps in my notes. And Roshalda, yes, there will be a recording made available. It will be on the YouTube channel for NMQF. It usually goes up pretty quickly, but give it till next week and check and it'll be up. All right. We still have a few minutes. That's all the questions that are in now. But if you have any other questions, please feel free to drop them in. Oh, okay. Robert is still dropping us links. Thank you so much. So why we need both cultural humility and cultural competence, an excellent article. We will be sure to check that out. Thank you. As we kind of come to the end here, I would like to ask just of our panelists, y'all have dropped some nuggets, some pearls of wisdom, as Roshalda mentioned before. Are there any final thoughts that you have? Anything that one thing that you want to make sure everyone takes away from the webinar today? If you could share those with us. I'll give you a moment to think about it, but don't all jump in at once right now. Kimberly's off of mute, so.
Yeah, I think for me, it's just really knowing from yourself, what are you willing to unlearn in order to serve the people who trust you the most with your care?
I
Would be
love that.
the reflection that I would give.
That is a mic drop. Unlearning is one of the hardest things that we can do, but it is so important to do in this work, especially. All right. Dr. Yaba, I think you came off of mute next.
Oh, sure. No, I just love what Kimberly just said. That's definitely a drop mic. Really love that. But for me, again, just really going back to kindergarten, treating the other person as you would want to be treated. So seeing that person, listening to them, truly trying to understand them. I know we're all in a rush in our healthcare spaces. We need to get to the next patient or the next program or next project, but truly taking the time to stop, listen, and understand. That would be the nugget that I would share. Thank
And
you.
I'll just add to that to that nugget there of it's not just about the message, but it's also the messenger, and the message matters just as much as the messenger, essentially. And so to provide that culturally competent care, we really have to work from a place from learning and wanting to understand in order to address these issues and challenges within the workspace, and also avoiding one size fits all generalized assumptions within clinical practice, essentially.
Thank you. That's great. And I think as we wrap up, I'm just going to share a very quick story from my time as a caregiver for my aunt. She had stage 3, stage 4 was diagnosed breast cancer. And I had the privilege of taking care of her in her final year of life. And when we think about the patients that are the most underserved and what they kind of look like for social determinants of health, that was my aunt. She had low income. She had a high school education, but otherwise all of those challenges were there, and her care was excellent. She had a team that made sure that they did everything to get her to her appointments. If that meant that they had to pay for an Uber for her, they got her to her appointments. If I couldn't do it because of work, and it was during COVID that all of this was going on. When she started to have mental health challenges, because we don't incorporate that enough sometimes, but when those started to show up and I said, hey, you have to go get some care, they made sure that she got care. And I think about, and her doctor was really good because they also referred her for clinical trials, which is something that we know doesn't happen enough with Black and Brown patients, and referred her for clinical trials. Unfortunately, she was not able to participate, but just the fact that they brought it up and she was excited about it was enough to make me happy about her care and trusting of her care. And when we think about the little things like that, helping someone get to their appointments, making sure that you're talking to them about things in a way that they can understand. Even though it ended up being her last year of life, she wasn't able to, overcome the cancer. It made it so that it was a dignified process for her. Going through treatment, she went through it with dignity. And that was the most important thing to me, for her to make sure that she was getting what she needed out of it. So for the clinicians out there, for the care teams, whether you're a clinician or you are the receptionist or whomever, because everybody is responsible for delivering culturally humble care, it makes a difference in all of the ways that you can imagine, and even some of the ways that you can't. It truly does. And so just wanting to encourage all of us to take that in our public health work, in our clinical work, et cetera. It matters, and for the loved ones as well as for the people that you're caring for. So I would like to thank our esteemed panelists for joining us today and for sharing your nuggets and your wisdom. It has been a great conversation. We will include their information in a chat and an email out to you all, just so that if you want to learn more about them, you can. If you have any additional questions that pop up afterwards, you can reach out to us and we'll get them for you. If you want to learn more about the work at SHC, we will share our website link as well. We also are collecting stories. So we're offering anyone the opportunity to share their stories with us about cultural humility, whether you had a good experience, a not so good experience. We want to make sure that we collect those stories so we can share them out, because as we talked about, having those stories are of the utmost importance. So Brandon just dropped that link in the chat for us. Thank you, Brandon. And I see no other questions coming in, so we all will get 5 minutes back before I'm sure people are rushing to their next meetings, unless anybody has anything else they want to say.
Just thank you, Akeia and SHC, for this wonderful opportunity. It's been a wonderful conversation. Dr. Ruffin and Kimberly, very nice to meet you as well.
Likewise, it's truly a pleasure and grateful for the opportunity to be able to share and interface with a lot of great folks. Kimberly and Dr. Baislow, very happy and very thankful for the opportunity.
I will ditto what they both said. Thank you so much for the opportunity. It was great to take a part of this.
Thank you so much to you all, and I hope everyone has a good and relaxing weekend. Bye-bye.